Hello again. Welcome to Surgical Pathology Digital Slide Review and Sign Out. I'm Dr. Louis Hostel, and our cases are courtesy of the Digital Anatomic Pathology Academy, a joint venture with Digital Pathology Association and Pathology Presenter, Path Presenter. Today, we have another case. This is that of a 30-year-old woman who has an ovarian mass and a markedly elevated serum AFP. Traditionally, in younger women with ovarian lesions or abdominal pelvic symptoms, getting certain serum markers as a preoperative, pre-diagnostic measure is routine and good practice and can help to guide both the management and, in our case, the interpretation. So here's a representative section from this tumor. At low magnification, the thing that stands out to me is this fairly loose appearance, intervening areas of hemorrhage and congestion, open vessels, and not very cellular tumor tissue. We'll take a look in higher magnification, and I think we can begin to appreciate that this tumor has a sort of microcystic pattern, a very reticulated pattern, almost lace-like, if you will, which I think is a good adjective for this sort of pattern with very delicate appearing architecture and open cystic spaces. It's always good to make sure that that there's no other patterns available or hiding in the periphery, and we don't see other cell types in other areas of the tumor. So moving on to higher magnification, I think we can see that these cells are somewhat monomorphic. There's a degree of vacuolization to the cytoplasm in many of the cases. The nuclei are somewhat hyperchromatic and maybe mildly pleomorphic, although not terribly so. There are a few larger cells here, and the predominant population is fairly condensed, dark, reasonably small nuclei. We don't see a pattern of lymphocytes per se. We do see a few areas where there's a bit more pink cytoplasm, maybe some more epithelioid appearing cells in a few areas. So given the history of elevated serum AFP, our primary consideration, of course, in a germ cell type tumor of this sort would be Yolk Sac Tumor. And in fact, that is what we're looking at. This is the most common pattern with Yolk Sac tumors of the ovary, is this reticulated microvesicular type of pattern. Of course, it would be important to make sure that this is a isolated single type entity. We don't want to miss areas of other types of germ cell, either teratoma or any mixed germ cell features. And so both thoroughly evaluating our sections and thoroughly sampling the tissue that we receive is important to be able to state with confidence that it is only a pure Yolk Sac tumor, that there are no other elements. And of course, one of the challenges with Yolk Sac tumor is that it can have a variety of morphologies, this being the most common one, but there are a number of other morphologies that we can see with Yolk Sac tumor, including the polyvesicular vitelline structure, which tends to have larger vesicles, the hepatoid variants, which can look for all the world like hepatocellular carcinoma, various tubular, papillary, and of course the common endodermal sinus type morphologies. which would have the characteristic Schiller-Duval bodies. These, however, are only seen in a minority of yolk sac tumors, maybe 20% or so. Still, yolk sac tumor is the most common germ cell neoplasm in women after dysgerminoma, and almost always is presenting at a pediatric, adolescent, young adulthood type age, certainly pre-40 years of age. And elevated serum AFP is highly predictive for this neoplasm. Not unexpectedly, in immunohistochemistry will be positive with AFP, but also can be positive with germ cell marker SAL4 and glypican-3. In contrast, markers that are seen in dysgerminoma or in choriocarcinoma or other lesions such as CD30, CD117, OCT34, beta HCG are all negative in this tumor. And it would be important to differentiate from clear cell carcinoma. That's usually would be an older age group. Embryonal carcinomas, of course, could have some features of this, but usually have a higher degree of atypia and polymorphism of the glandular material. Dysgerminoma and some of the sex cord tumors, particularly Sertoli-Leidig tumor, can occasionally also look like yolk sac tumor. Juvenile granulosa soil tumor less frequently would masquerade as this. It would have to have a predominant follicular pattern to be mistaken for yolk sac tumor. Of course, yolk sac tumors are not unique to the ovary. They also occur in males. And here's a nice example from the testis. And as you can see, this again has this microvesicular pattern, polycystic type of change. In this particular case, however, we do see a greater degree of nuclear pleomorphism. As you can see here, these nuclei are a little bit more open and variable, some larger ones. But it also helps us to highlight another feature of this tumor, which can be useful, and that is the presence of hyaline droplets. Here you see one of these eosinophilic hyaline droplets here right in the center of the screen, sometimes in other locations. These can be both cytoplasmic and occasionally extracytoplasmic as well. For example, over here, I think you see one that may be extracytoplasmic, or they can at least appear extracytoplasmic. So those hyaline droplets also can be a helpful diagnostic clue to the diagnosis. In some clear cell tumors, you can also see hyaline material and occasional eosinophilic droplets like this, but usually with a different nuclear morphology than what we're seeing here. Now, grossly, not uncharacteristically, these tumors can be fairly large, and the cut surfaces will display a similar sort of soft, spongy type of appearance in this microvesicular pattern. They can be more solid and variable if there's mixed neoplasia or if they're dealing with the hepatoid variant and so forth. So variable consistency, not a uniform pattern in the gross evaluation. This photograph, courtesy of Dr. Scully's publication on this, of course, dating back to the 1970s. So our final sign out today is yolk sac tumor of the ovary, rising in a 30-year-old woman with elevated AFP. These lesions are usually quite treatable, usually are unilateral, and present at a relatively lower stage, but they may rupture or may be ruptured by the time of surgery. So thanks very much for being with me today. I hope you'll share some comments. Please feel free to subscribe to the channel. We intend to continue to post regular updates and share with your pathology colleagues as you see fit. We're trying to make this of educational value for trainees, for colleagues and peers, looking for a little bit of diversity on digital slide cases. So we'll see you next time. Thanks very much.